Hiremath, he is cardiovascular surgeon basically, but he is specializing in aortic surgery. So today's topic he has chosen modern day aortic surgery. But he is basically cardiac surgeon, he is also doing cardio, CABG and other cardiac surgery. So he is now senior consultant cardiovascular and aortic surgery in Indraprasth Apollo Hospital. He has come recently from Canada. He was working there as a cardiovascular surgeon. I think he was introduced few weeks back also to the forum. So just to my curiosity that he has chosen one specialty aortic surgery as his special interest. That's interesting. So let us hear from Dr. Niranjan Hiremath about the modern aortic surgery. Thank you. Please start your talk, Dr. Niranjan.
Thank you, sir, for your kind words, and thank you to Chauhan sir for such gracious words every single time he introduces me to the group. It's absolute honor to be here today, and I'm here to talk about modern aortic surgery. It's something which I love and I'm passionate about, and I hope I'm able to convince the group here, the esteemed faculty here about aortic surgery. As sir just introduced, I started off as a vascular surgeon, and during my vascular surgery days, this is about 12 years ago, and I was part of a few open thoracoabdominal aortic aneurysm surgeries, and unfortunately those patients did not have a favorable outcome. It kept me wondering as to why is it so difficult to do this, if you have a cardiac surgeon on board, if you have a vascular surgeon on board, and I felt that there was something missing, and that's when I fell in love with aortic surgery. And it's been about 10 years now. I'm trying to hone my skills and trying to find ways to make this better. As we all know, aortic pathology is one of the most deadliest diseases of the cardiovascular system. In that, importantly, is the aortic dissections that occur, which are usually emergent. Type A aortic dissections, the moment they occur, we have 25% mortality rate, and every hour they wait, the patient waits for surgery, the mortality rate goes up by 1%. And usually by 24-48 hours, if the patient is unlucky, usually they don't make it beyond that period. But if they do, if they are lucky enough to get surgery done and their aorta replaced where it's damaged, then there are 75% chances of their survival for 2 weeks, and after successful surgery, there's 75% chances of survival at 5 years also. Some of the largest centers have reported 10-year survival rates of 40 to 60%, and there are various classifications for aortic diseases. Aortic pathology is in full spectrum, includes aortic aneurysms, the 4 types of aortic aneurysms, thoracic aortic aneurysms, arch aneurysms, descending aneurysms, root aneurysms, the whole spectrum. And we have to understand that aorta is a multi-systemic organ, and it involves the whole body essentially, and replacing it means we need to have the expertise, skill and knowledge of how the entire system works in tandem. Some of the early results that were reported regarding when should we intervene on aortas, these are based on the International Registry of Acute Aortic Dissections, IRAD registry, which is an international registry, mostly of Western population. The cutoff point, or according to guidelines for aortic interventions, is 50 millimeters or 5 centimeters. And anything above that, the risk of rupture or aortic dissection dramatically increases. But I would like to point out here, in IRAD registry, if you look at the type A aortic dissection incidence and the diameter of aorta at the time of aortic dissection, 60% of them were in the measurement of 4.5 centimeters to 5.5 centimeters, which is really about 4.5 to 5 centimeters, so to speak. Some of the earliest aortic repairs that were proposed were just aneurysmography, cellophane taping of the aneurysm, covering it up and sealing it with a sealant, but none of them were long-term durable repairs. And these gentlemen are some of the legendary surgeons who pioneered modern aortic surgery, namely Michael DeBakey, who's from Texas Heart Institute. In 1948, he devised ways of tackling aortic aneurysms, followed by Denton Cooley. I think many of us obviously know about this great person, and followed by Crawford, who pioneered aortic surgery, which is being practiced even till today. Ironically, Dr. DeBakey died of a type A aortic dissection, exactly the disease that he classified. There's a picture of Dr. DeBakey designing his own aortic grafts on his wife's sewing machine, and he designed the first early models of aortic grafts, which included with branches, without branches, and even till today, they are in use, albeit with better materials. Talking about aortic valves, I think many of the esteemed senior colleagues may have seen some of these valves. Way back in 1952, we had the Hufnagel valve and the ball and cage system, the tilting disc prosthesis. Even our TTK Chitra valve, our very own indigenous Indian valve, is based on Jacques Shirley valve, which is basically a single tilting disc. And then followed by bioprosthetic valves and other mechanical valves that came into use, to the modern day, which is TAVI valves and sutureless valves. The most commonly used prosthetic valves are these St. Jude's mechanical valve or bioprosthetic valves, and essentially you just cut out the diseased valve and replace it with these valves, and they have a limited shelf life, they have limited durability in the patient. If you're putting in a mechanical valve, of course, the patient's on long-term anticoagulation and he has risk of cerebral bleeds. But if you put them on bioprosthetic valve, the valve starts degenerating at around 8 years and lasts about 15 years, depending on the size of the valve that is implanted in the first sitting. The new technology, TAVI, has really caught up in the modern world, and probably the most talked about valve in cardiovascular surgery or cardiovascular medicine are the TAVI valves. Especially after Partner 3 trial came out, which said that TAVI is superior to surgical aortic valve replacements in low-risk patients, there was suddenly a boom in the industry. Almost every other patient who had aortic stenosis would get a TAVI valve, irrespective of their age. And I've seen this personally, and I'm still seeing it. But the caveat of the Partner 3 trial was the patients that were chosen, low risk, was 75-year-old, which means the average life expectancy of these patients weren't exactly considered, and they were just replaced with the TAVI valve. And we do not have a long-term follow-up, or like a 10-year follow-up, to actually know how the TAVI valves behave. Now, I had the opportunity to train in TAVI in Canada, and I performed more than 100 transcatheter aortic valves as a surgeon, and along with transcatheter mitral and transcatheter tricuspid valves. We have to treat aortic valve regurgitation or stenosis as a lifetime disease. It is not a one-time solution that you replace the valve and you forget about the patient. This is an excellent graphical representation that was published in European Heart Journal very recently, where they map out very well the age of the person versus life expectancy to what kind of valve ideally a person should get. But we have to understand that our Indian patients have smaller aortic valve. So I actually looked into the data. We have a publication from Tamil Nadu, where they pointed out that compared to Western population, our aortic annulus, average aortic annulus size is less by 2 to 4 millimeters compared to Western population. Which means if we have higher body surface area, obesity is on the rise, diabetes is on the rise, but we have a small aortic annulus, we end up putting a 21 valve, 19 valve. The patients, one, the degeneration is much more accelerated, the symptoms come back very quickly, and second, it's not a long-term treatment. If you put in a TAVI valve, you're thinking about, essentially TAVI is you're squishing the aortic valve, the native aortic valve, putting in a valve. The patient comes back with another stenosis within 6 or 7 years. You put in another aortic valve into that, and eventually you're not left with any space. And these patients, which have not been chosen appropriately, come to us for TAVI valve explantation. And this is, according to AATS, is the fastest growing cardiac surgical procedure, that is TAVI explantation. This increases the in-hospital mortality by 11%, stroke rate by 15%, and the outcomes are not great. Some of them, they damage the aortic wall, so they need ascending aortic replacement. So you're essentially putting in a pathology, removing a pathology and putting in a pathology. Yes, if you choose your cases right, look at the average life expectancy of the patient, look at the annular size, look at the calcium burden, look at the type of valve you're putting it in, whether it's a bicuspid valve or tricuspid valve, because the Partner 3 trial actually excluded bicuspid valves. This is hot off the press. In 2023, this was published last week. They went back and looked at surgical aortic valve replacements in low-risk patients. This is a counter to the Partner 3 trial to say why isn't surgical aortic valve replacement same or superior to TAVIs. But what we found is at 5 years, the surgical aortic valve durability is equivalent to a TAVI valve, provided the right cases are chosen. But what is the advantage of doing a surgical aortic valve replacement? Main thing is we remove the native pathology. We decalcify the valve, we debulk the valve, and then we put in a TAVI valve. And when we are doing, then we put in a surgical valve. And the first surgical valve that we implant should be the biggest possible surgical valve that particular patient should get, so that you are lining up the patient for a valve-in-valve TAVI later, and he will get an appropriate treatment. But there's a caveat for surgical aortic valve replacements too. The problem is the current or the historically over the last 20 years, the number of biprosthetic valves that have come across, they are actually, the inner diameter is not a true label diameter. This paper measured the inner diameter of all these valves, and what was found is these are all 27 millimeter valves or 2.7 centimeter sized valves. But their true inner diameter was anywhere between 2 millimeters to 5 millimeters lesser than the label diameter, which means a 27 label diameter for a Medtronic mosaic valve was just 21 millimeters, which is really, really small. So you think, or we think, that we have done the best possible surgery by putting in a big valve, but unfortunately the patient has actually, in effect, got a 21 millimeter valve. The modern valve, Medtronic Avalus and Edwards McNally, the workhorse of all cardiac surgeons today, are the least discrepant when it comes to inner diameter. So what is the solution for small aortic valves? One of my favorite surgeries is the root enlargement surgery. This is not the traditional root enlargement where we used to go down to the mitral valve and enlarge the aortic root. This is a subannular inverted Y annuloplasty, where here you can see that the Dacron patch is placed. It's a nice square patch at the bottom here. I'm sorry. There, that's the square Dacron patch that is at the annulus, and it helps us increase the size of the valve by about 5 millimeters. If a patient has a 19 mm annulus, we can actually put in a 25 mm valve or a 27 mm valve in such a small annulus. So you are preparing this patient for a future valve-in-valve TAVI, because the patient only gets older and frailer, so TAVI is a better option in the future. But if he's fit at the time of baseline surgery, we should take it. This is a bovine heart that I was teaching my associate last week on how to do the aortic root enlargement. It's very nicely seen. The Dacron patch that we sew in after we enlarge the annulus, and eventually it will look like this, and this can admit a valve size 4 or 5 millimeters more. Aortic aneurysms, especially the root aneurysms, are quite complex too. The problem here is you have to deal with the coronaries, you have to deal with myocardial protection and the associated aortic valve pathologies. The most common procedures performed are Bentals. Then we do the aortic homografts. This is a case of aortic homograft implantation that I published when I was in Cleveland Clinic, where we inverted this aortic root prosthesis into a horribly destroyed aortic annulus. We sutured it and brought it out of the LVOT. This is to aid putting in a good sized valve in a very small aortic root. This technique was proved to be a lifesaver for this patient. But we as surgeons, we've always been taught, respect, don't resect your valves. Try to maintain or try to keep the patient's own valve. And these two great gentlemen, Dr. Yakub and Dr. David, were the first ones to introduce valve-sparing aortic root surgeries. The idea of valve-sparing root surgeries is you repair the aneurysm around the root and the aorta, but if your aortic valve is healthy, do not resect it. We save it, and I have seen the longest durability of this repair for more than 20 years. And the patient is free of anticoagulation. Sometimes the patient doesn't even need aspirin after 6 months. This is a case of aortic valve sparing procedure called the Davis procedure, where we re-implant the sinuses, and as you can see, the coaptation, the Mercedes-Benz sign of the aortic valve is clearly seen, and the saline test that we are doing shows the competence of the valve. There's another case using an alternative technique called remodeling of the aortic sinuses, where you can see the aortic valve beautifully coapting, and this is the patient's own valve, and this is the graft that we use to reconstruct the aortic root. This is another case of Yakub's procedure, which we were checking for competence. As you can see, the tri-leaflet aortic valve is beautifully seen here. The sinuses are repaired already, and we are checking for hemostasis. Aortic arch aneurysms essentially are complex because we have to deal with cerebral circulation, which means increased perioperative stroke or postoperative stroke, and some of these patients present with hoarseness of voice or aortopulmonary fistulas, and they usually require extensive planning. Some of the arch traditional surgeries are the elephant trunk procedures, which I think many of us would or would not have heard. Basically, we repair the arch in the first stage and we leave a dacron graft dangling in the rest of the aneurysm to be caught later from a thoracotomy, and then we complete the entire replacement of the aorta. But now we have modern procedures and modern devices. This is a device which I am trained in and I use it, and it's available here at Apollo. Is the Thoraflex hybrid graft. It consists of the open surgical graft followed by an endovascular stent graft that's deployed into the descending aneurysm, essentially treating the entire complex arch in one sitting. There's an example of a 74-year-old Chinese man I treated in Canada. This gentleman presented with a penetrating aortic ulcer, ruptured into the pericardial sac. He had pericardial effusion, tamponade. He came on high inotropic supports, and we took him for emergency surgery at 1 a.m. We did a Thoraflex hybrid graft, which I showed earlier, and we deployed this stent in the descending aorta. But this gentleman's transverse arch was tricky. It was much more straighter and longer than we anticipated, and we were not able to cover the entire aneurysm, but we only repaired the ruptured part. We thought we could bring him in again for a second stage operation about 6 months down the line. But in 2 weeks, this gentleman's aortic diameter increased by 1.3 centimeters, which was an indication for completion. So I planned this entire case on a 3D reconstruction software. I ordered the stent grafts and I performed an endovascular procedure. So this is the entire treated aortic aneurysm from the ascending all the way down to the descending aorta in one shot. The biggest so-called beasts or monsters of cardiovascular system are the thoracoabdominal aortic aneurysms. These are some of the most complex diseases that we see in human bodies, and usually there are select high volume centers who have excellent results with these pathologies. The traditional technique is we lay the patient down like this on his lateral decubitus position, and we split open his entire body, which includes the entire thorax and the abdomen, like a salmon fish, and then we divide the diaphragm and to access this entire aorta. This is a very morbid surgery. It needs a lot of dexterity, expertise, and speed because it's one of the most bloodiest operations. The amount of blood required on an average for a thoracoabdominal surgery is anywhere between 15 to 20 units of packed cells, 20 units of FFPs, and 20 units of platelets. This is like a standard for thoracoabdominal surgeries. And it's a whole day procedure. You need surgeons of at least 4 surgeons. You need a cardiac surgeon, you need a vascular surgeon, you need an interventional radiologist, you need an extra hand to retract your abdomen and abdominal contents. And the whole aorta is replaced using a special cardiopulmonary bypass circuit. You cool the patient, hypothermia, stop the circulation for maybe 30 minutes, 40 minutes, 45 minutes, and you perform the entire surgery. And the best possible outcomes that are seen are from Texas Heart, where they have done close to 3,000 of these surgeries. That's the only center that's done that kind of volume. But rest of us, we don't have that kind of volume. So that got me thinking, is there a better way to do this? Fortunately, in Cleveland Clinic Abu Dhabi, I had an opportunity to devise a technique where I called it the modified branch first technique for thoracoabdominal surgeries. And this was published in JBS, American Journal, Operative Techniques Atlas, which is an invited article, JTCBS Techniques as an innovative technique, and Indian Journal of Cardiothoracic Surgeons was an invited article. And I illustrated this technique to show that we could bypass this aneurysm, take care of the visceral branches first without opening the entire aneurysm. By doing this, you are providing uninterrupted flow to the visceral organs. The descending aorta is pumping blood to the visceral organs. You've still not opened the aorta, so there's no bleeding. And spinal cord perfusion is still intact. And once you finish that part, you do the proximal anastomosis just by a simple clamp. At this point, there is an interruption in flow, and that is about 5 to 10 minutes. The moment that is removed, the entire aorta gets perfused straight into the viscera, and we complete the final one. When we do this, the bleeding is dramatically less, and this is another complex aneurysm that I used left heart, left atrium to get the blood to the graft, and this is how the graft was kept on the aneurysm. This is the aorta, aneurysmal aorta, which is not open yet. And I've designed this special perfusion circuit, which is connected basically in a way where I try to do this surgery without going on heart-lung machine, but if I fail to do so, there is a backup to go on bypass right away within 5 minutes. And this is the pre and post. This is a luminogram, so let's not get misled by the diameter of the aorta. The outer diameter is much larger than what we see here. And this is a completely treated aortic aneurysm. It's hard to even say that this part was replaced. Aortic surgery is a team game. As I mentioned, at any given point of time in the surgical theatre, there are at least 10 to 15 personnel. Here at Apollo Enterprise, Apollo Aortic program, which we recently started, we did our, this is just the second case, and it turned out to be a complex type 4 thoracoabdominal aortic aneurysm. This lady is a very pleasant 46-year-old from Panipat. She presented to the emergency with severe back pain, uncontrolled hypertension, loss of appetite, weight loss. She had stage 2 chronic kidney disease, and she came to the emergency with a large pulsatile mass in her abdomen. We sent her to the CT, and we found she had a 13 centimeter thoracoabdominal aortic aneurysm. Distorted vascular anatomy. Surprisingly, she was given 100% mortality risk by major centers in Delhi NCR. At least 3 or 4 she named, which I wouldn't like to name right now. And the patient refused to get it treated due to the fear of operative mortality, and she walked around with this massive 13 centimeter aneurysm for 1.5 years. when she presented to us, it was impending rupture. If she had ruptured, she would have died within 5 seconds maybe. And that's how big the aneurysm. Again, this is a luminogram. The actual diameter is 13 centimeters. This included the celiac and the SMA. SMA was pushed to the right side. It looked like a renal artery. Both the renal arteries were occluded, unfortunately, due to chronic thrombus formation. And she was already in renal failure. And this patient was taken as high-risk surgery. She was anemic. She had CKD. We did every kind of strategy possible to optimize her before the surgery. We devised our own way of doing this because this was very complex and I anticipated on-table mortality of 30%. So I told the family that I will attempt this using our technique, and we designed this unique technique using this branch graft where we would go on bypass. I tried to do it without going on bypass, but it was not possible. We took 5 hours to dissect this aneurysm. I will show you in the next slide how it looked. It was a massive ostrich egg. And then eventually when we thought it was too high risk and this patient will rupture right now, we went on bypass. We cannulated the left femoral vein, which was already ready, and then we went on bypass with a triple inflow. The traditional bypass is we only use one single arterial line, but we connected 3 different arterial lines, and we perfused the viscera, we perfused the brain, we perfused the lower limb. So even if we stopped the circulation was going through alternative ways. So we maintained the normal physiology of the patient. We maintained the normal physiology of the patient, full body perfusion, beating heart, normothermia. We did not cool the patient, and we were able to repair this. It took us a whopping 14 hours to do this procedure, but eventually we came out with this result. This is a huge aneurysm here. That's the amount of thrombus that was there in the aneurysm, and this is the straight diaphragm graft. And that's the before and the after picture. All the vascular tree is intact. I love to have my patients start walking on day 1 ideally, but this lady was walking on day 2 after removal of CSF drain, and she made a remarkable recovery. In fact, today she was discharged uneventfully. And this is my first case, which I did ABR-CABG with ABR-CABG. This gentleman from Arunachal Pradesh, I did an extrapleural left internal mammary harvest skeletonized. So the lungs were not open, the lung space was not open, and he received a skeletonized mammary, and we did an aortic valve replacement, also walking on the first day after surgery. So I would like to summarize aortic surgeon is one who can do open aortic surgery, a person who can do endovascular surgery, hybrid aortic surgery, as well as transcatheter valve. And a true aortic surgeon is one who has an understanding of the entire spectrum of pathology. At the end of the day, I'm sure that all my seniors that are here would agree, it's ultimately patient satisfaction. This is a lady today at the time of discharge, and she gave me a nice hug. And that's the first patient who received the world's first modified branch first. He's an Egyptian gentleman. He went scuba diving and jet skiing just within 3 months after his surgery. And that was in Cleveland Clinic, Abu Dhabi. This is the entire team that was involved last week. I'm always grateful to the team. It's a team effort. It's never a single person. Thank you very much.
Thank you, Dr. Niranjan. So we'll take questions at the end of the second lecture. Just I forgot to mention about one, and he's the first surgeon in India to hold double super specialty degree in cardiothoracic surgery as well as endovascular surgery. So Dr. Niranjan, we'll take questions. You can join here.
I am here to moderate one session. It's my duty to introduce Dr. Yogesh Batra, who needs no introduction from our group. And I have attended many of his CMEs, very nice orator, and really a gentleman gastroenterologist. So he has done his graduation and post-graduation, graduation from Kanpur and DM from AIMS. He was there with AIMS from 2000 to 2004. He was trained in endoscopy in Germany and Hong Kong, and also trained from US. He has been senior consultant with Gangaram Hospital, senior consultant at Batra and Holy Family Hospital. He was director gastroenterology BLK Hospital from 2012 to 2018. Therefrom, till now, he is with Apollo Hospitals as senior consultant gastroenterologist. He has many research publications and 6 book chapters. So, topic for today is IBD, inflammatory bowel disease, which primarily Crohn's and ulcerative colitis. So, we all have had many such talks on this topic. I think we will learn much more today, and I will request Dr. to make it short so that we have more interaction, because this topic is so close to our heart. I am not saying that aortic was not close to our heart, it was part of the heart, but we are more into physician kind of practice, more of your domain, sir.
Thank you for the kind introduction, sir. It's always a privilege to be back to Physicians Forum, probably the only functional forum in the city or probably the country which has done 854 presentations in a row. Thank you so much. Dr. Chauhan, Dr. Poddar, Dr. Tulsi, and all my other friends. So today I have changed tracks. Normally when I come to you I speak about endoscopy, but today I would be speaking about inflammatory bowel disease. And the reason for this is that there has been a sharp increase in the incidence of IBD. So when I was training at AIMS, whenever somebody said that this patient has Crohn's disease, I would be ready to fight. Crohn's India mein hota hi nahi hai. There is no question about Crohn's disease. But today in my OPD, I see at least one new patient of Crohn's disease every day. That is the gross increase in incidence which is taking place. And this is matched by data also. This is worldwide data which is coming up. And India is matching this. US actually is now plateauing out, but India is going on increasing. And the reason for this is most probably the change in our dietary habits. So starting with a few cases. This is a lady who came to me recently. She had recurrent episodes of abdominal pain for the last 20 years. She was anemic for the last 20 years. Had been investigated in various clinics and various physicians. Was not diagnosed at all. Anemia hota tha, would receive iron, it would get corrected, would go from doctor to doctor, nothing happening. Finally, we decided to do a CT scan, and this is what we found in the CT scan, that the ileum was completely thickened. We decided to go in for colonoscopy, and this is what we found in colonoscopy, large ileal ulcers. There was also a fistula in the anal region, so she was treated with a sit-on placement for the fistula. We treated her with biologics for the Crohn's, and she's been asymptomatic for the last 10 years. Surprisingly, her own daughter-in-law, IBD is more common in families, that is very well known, but how come the daughter-in-law also had she came up with an intestinal obstruction, and this is what we found on CT when she came, that there was an obstruction at the ileocecal region. We did a colonoscopy, found the ileal stricture, and then we decided to dilate the stricture, which we managed. And post dilatation, this is what the stricture looked like. The obstruction resolved completely. So this is another case which she also had pain abdomen for quite some time and was running from pillar to post undiagnosed. This is the third patient. This is usually the most common presentation of IBD in our settings, that someone has a bleed. This bleed is diagnosed as a hemorrhoidal bleed. Even hemorrhoid surgery or hemorrhoid injection is done and then nothing happens. The patient continues to bleed. So finally, after years of bleeding, someone decides कि नहीं इसकी colonoscopy कर लेनी चाहिए. So he is referred for colonoscopy. So once colonoscopy is done, this is the kind of picture we find, that this is florid ulcerative colitis. And after that, treatment begins, starting first with immunomodulators and then later, if required, extending to biologics. So these are the three kind of cases. These are representative cases, and these are the kind of patients who are running around from pillar to post. They don't have any particular diagnosis, and they spend years undiagnosed. So through this talk today, I want to create more awareness about this entity and how we should go about managing them. So inflammatory bowel disease consists of ulcerative colitis and Crohn's disease. So it can be ulcerative colitis, Crohn's and unclassified. IBD is characterized by chronic immune-mediated inflammation in the gastrointestinal tract. It is a progressive destructive disease. IBD is not IBS. So IBS is irritable bowel syndrome while IBD is inflammatory bowel disease. So in our OPDs, we get a lot of patients who complain of bowel gas, bloating, constipation, that is all IBS. Here we are talking about a chronic destructive disease which can actually lead to strictures, to fistulas, to bleeding. That is IBD. Incidence of IBD, as I told you, is significantly increasing. And what is causing this incidence to increase? So a number of factors. Smoking, antibiotic use in childhood, lack of breastfeeding, oral contraceptives, appendectomy, low vitamin D levels, tea coffee consumption. These are some of the factors, but what is more logical and what is more considered to be more common is the changing dietary patterns. So we are following the diet of the West, and when we say that we are following the diet of the West, that means that our own traditional diets are going away. And we are going more the fast food way. Fast food is considered to be having things like mayonnaise, sauces, preservatives. And these preservatives, sauces which are there in fast food are causing a complete destruction of the GI tract. So this is the prevalent hypothesis today of IBD. Coming to ulcerative colitis presents with the rectal bleeding, frequent small volume loose stools, mucus discharge from the rectum, tenesmus, urgency and rectal pain. While Crohn's disease present is an inflammatory conditions involving the small bowel, present with abdominal pain, diarrhea, fever, malabsorption. Colonic Crohn's can present with diarrhea or hematophagia. They can be stricturing, or if there is penetrating Crohn's, they can be abscesses or fistula. So, mota, ulcerative colitis involves a large bowel, Crohn's involves a small bowel. Ulcerative colitis presents with bleeding, Crohn's presents with penetrating disease, strictures, fistulae, abscesses. So, comparing ulcerative colitis to Crohn's, ulcerative colitis involves the colon and rectum. Crohn's can involve any part of the GI tract. Ulcerative colitis rectum is universally involved. Crohn's rectum is involved only in 10% of cases, and this is known as Crohn's colitis. Ulcerative colitis is mucosal and submucosal. Crohn's is transmural injury. It goes through the muscle. Leads to strictures and fistula, including perianal involvement. Ulcerative colitis has a continuous pattern of inflammation. Crohn's has skip lesions. So there might be rectal involvement, then might be transverse colon, and then cecum straight away, and then the small bowel. Ulcerative colitis is usually acute in onset. So patient will suddenly present with GI bleeding, and on colonoscopy you will find ulcerative colitis. While Crohn's disease is low-grade abdominal pain persisting for a long period of time, and suddenly there is complete intestinal obstruction. This is what ulcerative colitis and Crohn's looks like, or this is how we classify it. So for ulcerative colitis, 40 to 50% of patients will have proctitis or proctosigmoiditis, so rectum and sigmoid colon. It could be left-sided or extensive colitis. So if it is up to the splenic flexure, it is left-sided. If it is involving the entire colon, it is pancreatitis. On the other hand, for Crohn's, the disease is predominantly ileal or ileocolonic in 40%. This is the maximum patient present like this. It may be small intestinal in 30 to 40%, where there can be skip lesions. It can be Crohn's colitis in 20%, with different areas of the colon being involved. Or it can be perineal disease. So there can be fistulas, there can be abscesses formed in the perianal region. Ulcerative colitis and Crohn's are immune-mediated diseases. So immune-mediated diseases will have not just intestinal effects, they will also have extra-intestinal effects. So extra-intestinal disease can be throughout the body. They can be conjunctivitis, episcleritis, mouth ulcers, fatty liver, liver abscess, portal pyemia, mesenteric or portal vein thrombosis, venous thrombosis, autoimmune hepatitis, arthralgia of the large joints, erythema nodosum or pyoderma gangrenosum. This is what pyoderma gangrenosum looks like, and when I had seen this about 5 years ago for the first time, I could not recognize it because I had never seen something so florid in my life. It is like ugly, large blisters on the skin, and it can occur in any part, and then they can be in large numbers, 4, 5, 6 of them. This is spinal changes occurring in a patient of ulcerative colitis. So what about the complications of IBD? So IBD is not a simple disease. It is a spectrum. It can be mild, but it can have severe complications also. Severe complications can be severe colitis, they can be perforation, they can be hemorrhage, they can be toxic megacolon. So this is an X-ray of a patient with toxic megacolon where the intestinal, the colonic dimension has increased to more than 6 centimeters. They can be fistulas, so these are multiple fistulas in the perianal region in a patient, or eventually it can lead to carcinoma colon. So those who have ulcerative colitis more than 8 years have a risk of developing CA colon. It is a pre-malignant condition for development of CA colon. What about differential diagnosis? So it can be confused with bacterial, viral or protozoal colitis. So first time you have a patient who has mild fever or even without fever presents with GI bleed, you go and you get this kind of a picture. This could be the first presentation of ulcerative colitis, or it could be infective colitis. So the approach is that you treat with antibiotics for 2 to 3 weeks, go in again and see what has happened to the changes. Among the non-infective causes, they could be vascular, drugs or neoplastic causes. They could be in small bowel, other causes in the right iliac fossa mass, cecal carcinoma, appendicular mass, infections like TB, Yersinia, actinomycosis, mesenteric adenitis, pelvic inflammatory disease, lymphoma and eosinophilic gastroenteritis. So before labeling anyone as IBD, we have to keep all these in our mind. How do you investigate? So simple lab tests, what is important is CRP, which tells us about inflammation, endoscopy or colonoscopy. When do we do endoscopy? For the diagnosis, disease extent, presence of strictures and fistula, for endotherapy, differentiation between UC and Crohn's, biopsy for C. diff and CMV, and for follow-up. And in radiology, you do a barium, CT and MR. Barium has now been given up, so it is CT and MR, and that too enterography mostly. So this is what we get in ulcerative colitis. So this is normal mucosa, this is mild inflammation. So by mild inflammation we mean that there is loss of vascularity. ये जो veins दिख रही हैं ये गायब हो जाती हैं. Then there is moderate inflammation where ulcers start appearing. There is granularity. And then there is severe inflammation. And this is what we get in Crohn's. So this is normal mucosa again. These are aphthous ulcers. So this is an ulcer around which there is surrounding erythema. A classical aphthous ulcer which can also be found in amoebic colitis. But these ulcers in Crohn's can be found throughout the small bowel. This is relatively severe colitis, and these are the serpiginous ulcers of Crohn's which are found in the colon. So two things which are very common about Crohn's, classically taught in our undergraduate textbooks. One is serpiginous ulcers, the other is cobblestone. So in between these ulcers, when these ulcers have a transverse pattern also, the mucosa becomes elevated. So they become like cobblestones. जो सड़क के जो पत्थर होते हैं उस तरह के बीच में गैप्स होते हैं and then the stones come up. Coming to imaging, we do CT where for ulcerative colitis we have a thickened colon like this. You can get dilated bowel loops, pseudopolyps, and you can know the extent of the disease. For Crohn's, you can get mural enhancement, you can get strictures, fistulas, and abscesses. So this is a intestinal vesicle fistula and introvesical fistula. The intestine is communicating to the urinary bladder. Another new test which we use quite often is capsule endoscopy. So when we don't find anything and the CT is normal, then we go in for something known as capsule endoscopy, and these are the kind of ulcers which you can pick up on capsule endoscopy. So once you have found what kind of disease it is, whether it's ulcerative colitis and whether it is Crohn's, how to treat it. So there are two basic components of treatment. One is induction of remission. The second is maintenance of remission. So by induction of remission we mean that we have to control the disease so that the acute flare goes away. जो आग लगी हुई है वो बुझाना है. And then we have to make sure that the fire does not come up again. So that is maintenance of remission. So turning off the inflammation is induction. Then for maintenance, we have to make sure that there are no steroids. So we were just discussing outside a child who was on steroids for a long period of time, at least had two 40-day courses of steroids. So if you use steroids for a long period of time, then you end up causing a lot of side effects. So steroid-related side effects have to be avoided. So steroids cannot be used for maintenance of these patients. And finally, you have to monitor disease and you have to prevent long-term complications like malignancy. Something which there has been a thought block about, and that is that ulcerative colitis or IBD, for example, cannot be cured. So with the advent of newer medication, ulcerative colitis can be cured completely. And this is a picture of a patient who had severe ulcerative colitis, and this is after adequate treatment. This is the Bible of treatment. So these are guidelines, European guidelines for ulcerative colitis and Crohn's, and these, the latest edition, were published in 2021. How do we treat? The first set of drugs is ASA. These are aspirin-like drugs which reduce inflammation. So they come either as prodrugs, they can be attached to another moiety like sulfasalazine is commonly available, we use it for all kinds of arthritis. Then they can be pH coated so that they are released in the distal ileum and colon. So Esacol is available in India, so is Pentasa and Roas. So they come as tablets or they can come as sachet. Topical ASA preparations can also be available as suppositories, enema or foam. These are used for distal colitis. For patients who have proctitis, these can be used. The adverse effect of 5-ASA is that they can cause fever, rash, nausea, vomiting and headache, hypersensitivity reactions, reversible sperm abnormalities and impairment of follicle function. Steroids we all know about. There have been multiple discussions of which steroids, so probably the most commonly used steroids is prednisolone. Immunomodulators. Again, azoran or azathioprine is the commonest used immunomodulator. The rest are mostly not used anymore because of the advent of biologics. So biologics are a new set of drugs which alter immunity, and the basic set of biologics are TNF inhibitors. So TNF inhibitors mean essentially infliximab and adalimumab. These two are available in India. The second set is IL-2, IL-12 inhibitors, that is ustekinumab, which is also available, comes by the name of Stelara. And then anti-integrins, which is vedolizumab. This also is available with us now. And finally, small molecules or JAK2 inhibitors. We need not get into the immune mechanisms, but essentially what I am trying to say is that immunity is a very complex process, and immunity can be suppressed at various levels. The commonest being TNF, followed by anti-integrins, anti-IL-2 and JAK2 inhibitors. Infliximab comes by the name of Remicade, one of the most effective drugs. But then drugs which are effective also have the most side effects. These are some of the trials. What is astounding is that for induction, almost nearly 70% patients had a response. None of the biologics which followed infliximab so far have had this kind of a result. Similarly, high response rates even for maintenance, about 45%. What about adverse effects? So 4 to 16% can have adverse effects. Development of anti-infliximab antibodies in 10 to 20%, which can cause acute reactions like dyspnea, tightness, rash. This is less likely in those in which infliximab is combined with steroids and immunomodulators. So do not use infliximab alone, use it along with azoran. Delayed reactions have also been reported. Anti-lupus-like syndromes are reported. The most scary complication for us is reactivation of tuberculosis. So in India, we have a vast population which has latent tuberculosis, and whenever we give drugs which modulate immunity, this tuberculosis can come. So this is a major risk. There can also be a reactivation of hepatitis B and C. Second anti-TNF is adalimumab, comes by various names, Exentia, Mebura and a host of other names, because this has now become a biosimilar also. So this is not a true biologic. The formula has been copied, and a synthetic derivative known as biosimilar is also available, and hence the cost has come down to almost about 6,000 rupees. This is to be taken twice in a month, and among the trials, the response rate on paper seems to be about 18%, but I have about 25 patients on this, and all of them seems to be doing well. The next advance was vedolizumab and ustekinumab. The advantage of these drugs is that they are very, very safe. They do not cause reactivation of infections, they do not cause lymphomas, they do not cause any of the side effects of infliximab. Tofacitinib is so far recommended for use only in ulcerative colitis because in Crohn's disease, the trials did not show that much efficacy. Has about 20% improvement in Crohn's disease, in ulcerative colitis. It is used for induction of ulcerative colitis. Side effects here, the most troublesome side effects is development of herpes zoster. So therefore it is recommended that those who are put on tofacitinib should have herpes vaccination. So much about drugs. Coming to diet. Diet in short, wheat and milk are considered to be pro-inflammatory. So diet in IBD is now thought to be diet without wheat and milk. What is recommended is the Mediterranean diet, which consists of greens, fruits, fish, chicken, olive oil and vegetables. So essentially what we used to do in our heydays, or what our forefather used to do, is what is recommended now. You're supposed to avoid fast foods. Omega-3 fatty acids and curcumin again have been found to be helpful. New things which are coming up, probiotics like VSL3, maximum data on VSL3, it is a branded probiotic, but then the studies which were conducted with the combination of bacteria which was there in VSL3. Fecal microbiota transplant has come in a big way, but very messy, people don't like it, and the next step is going to be a pre-med capsule, a pre-med stool capsule, which you will be asking your patients to swallow. Probably that is what is going to happen in future. Apheresis to remove the antibodies, some antibiotics, and stem cell transplant. These are the future therapies which are going to come up. So what about present day? How do we treat IBD? For mild IBD, your options to induce or to maintain are corticosteroids, budesonide and aminosalicylates. Aminosalicylates only work in UC, they do not work in CD. So aminosalicylates should only be given in UC. They are helpful in both inducing and maintaining disease. They can be used orally, or if there is only prophylaxis, they can be used as a rectal preparation. Steroids are the best bet in very severe disease. They are helpful in both CD and UC. They are to be used only for induction, not for maintenance. They can be used oral, IV or rectal. Budesonide, less effective than steroids, but less side effects. Can be used both for CD and UC. Again, to be used only for induction, not for maintenance, come only as oral. There is a new preparation of budesonide, which is to be given once a day, which is for distal release, so released only in the corpus. Budesonide NMX. What about severe disease? So the options are thiopurines, which can be used both for CD and UC, can be used only for maintenance, not for induction. Thiopurine is basically is a thiopurine. Methotrexate hardly used now, so I would not talk about it. Anti-TNF agents means both infliximab and adalimumab can be used both for CD and UC. Can be used both for induction and maintenance, or IV in case of Remicade, or infliximab and subcutaneous in case of adalimumab. Vedolizumab, both CD and UC, both induction and maintenance, IV initially, and subcutaneous is in the pipeline and would come up soon. Natalizumab not available in India. Ustekinumab available both CD and UC, both for induction and for maintenance. IV for induction and then subcutaneous for maintenance. Tofacitinib only for UC, both for induction and maintenance, and it is an oral drug and it is quite cheap. So just a few slides between you and dinner. The concept of treatment could be a step-up approach or a step-down approach. A step-up approach is that you start with 5-ASA, increase to steroid, increase to azaran, increase to biologics, and then think of surgery. So, been literally reversed. When you start with biologics, because it is postulated that you hit hard and you hit effectively. So you start with biologics, control the disease, and after a year or two of biologics, then you start downgrading. Surgery is mostly out of the normal management protocol of IBD, and it is restricted only to those patients who have complications. Therefore, ladies and gentlemen, this is the summary or the take-home message. The incidence of IBD and prevalence of IBD is increasing very rapidly in India. IBD is diagnosed on a clinical presentation, radiology and biopsy. Early and prompt diagnosis is the key to preventing complications. The goal of treatment are clinical remission, that is mucosal healing and maintenance. Multiple therapeutic options are available and they are all good. With the advent of routine use of biologics, surgery for IBD has become a very rare entity. Most patients with IBD can live a normal life without any complications, with a quality of life which is parallel to those of a normal population. Thank you so much for your patience.
Dr. Kaza sir, Dr. Yogesh sir, please come here sir. Friends, I think all of you would agree that we had two wonderful presentations. And now therefore we would move to the question and answer session. It is exactly 10:15 and we would like to wind up by 10:35. So we have exactly 20 minutes. So over to Dr. Sen Gupta sir.
So, thank you so much for both the lectures, brilliant lectures both. My questions and two small comments directed towards Dr. Hiremath. You've been, by and large, you've been trained abroad also and out here. So, do you find any kind of a difference? Because we have alveolar disease more in the rheumatic variety. So, do you find any kind of a decrease in the incidence that you see, and any change in the procedural stuff that you need to do with respect to aortic valve disease?
Thank you, sir, for the question. Actually, there are two things that I've noticed that are different here in India. I'm seeing the incidence of bicuspid aortic valves more in India, which is quite actually surprising. The average incidence around the world is a 1 to 2%, but here I'm seeing at least in about 3% of the patients I've encountered. The second thing is that the size of the annulus for Indian patients is much lesser, as I just mentioned. So even if whether it's rheumatic or degenerative, rheumatic already we know that it's quite prevalent in India. So these patients come in quite young, and if say the patient is well built or at least moderately built, but the annulus is extremely small, it's important we put the right size valve in the first sitting, whether it's a mechanical valve or a bioprosthetic valve. So the incidence is there, it's just the pathology that's different, but the need of the hour is to choose what is the ideal valve size, and special attention to be paid for it.
So you need a very good echo, etc., and operative evaluation to, by and large, decide what you want to do.
That's right. If the preliminary echo report says anything suspicious of a small aortic annulus, then ideally we would do a CT, and that's the best way to measure the aortic annulus and the sinuses. That will give us a picture whether the patient, we index it. It's called the Z-score. So we index it to the patient's body surface area. If it turns out to be much smaller than his body surface area, then we have to do a root enlargement. So it becomes it's about 15-20 minutes additional procedural time.
Thank you so much. Do allow me to read out a small quote, because I am a member of the life member of the CSI, and incidentally just today there was a comment on Dr. D. Key. And since you said this, so he was born of Lebanese immigrants, educated by Doles and Brands, one of the finest doctors truly blessed, first to affirm that smoking is cursed. So I never knew that for medicine part of cardiology, he was the first person to say that smoking is bad. And like you said, he died of the same disease that he had diagnosed. And lastly, a small passing comment on, you mentioned about Yakub. I mean, speaking just very tangentially, one of the persons who have inspired me to take a medicine, Mahdi Yakub, born of Egypt, Alexandria, cleared FRCS, all 3 exams together, presently chief of the Brompton Heart and Lung, and phenomenal gentleman. So thank you so very much to take us through this journey. Thank you.
Thank you, sir.
Any other question for Dr. Niranjan?
I just want to add to that, Dr. Yakub's thing. The first case which I showed with the valve sparing, that patient is actually a redo case. It's a Ross autograft which was implanted by Dr. Yakub 21 years earlier. So the patient came back with aortic regurgitation. We spared the pulmonary autologous valve and we gave him an additional thing instead of replacing.
Dr. Niranjan, yeah, just a small question. There was a mention of PAU, penetrating aortic ulcer. So what are the causes for that? We never heard about PAU.
So it's one of the three main diseases of acute aortic syndrome. Aortic dissection, penetrating aortic ulcer, and aortic intramural hematoma or thickening of the aortic wall. So penetrating aortic ulcer is basically atherosclerosis, severe atherosclerosis of the aorta, where it erodes through the wall and it ruptures.
Just aortic, abdominal aortic aneurysm can present with severe pain abdomen. So we are talking about vascular disease where it can present as severe pain abdomen with features of shock.
Yes.
A ruptured aortic, abdominal aortic.
Absolutely. About 75% of the patients who have aortic aneurysms are asymptomatic.
Yes.
So it's actually a silent killer. And when it actually becomes symptomatic, it's either when it's rupturing, impending rupture, or the patient is lucky to have symptoms and get it picked up.
Yes. Yes, Dr. Tulsi. For Dr. Niranjan only.
Dr. Niranjan, once again a wonderful talk.
Thank you, sir.
So whatever, which is thoracic endovascular repair for aortic aneurysms, how big can an aneurysm grow before it bursts? Would you say 5.5 centimeters will rupture within a year, and probably in 3 to 6% of the people. So repair is highly recommended for such patients. And what stent graft are you using? Are you using the metal with a probably polyethylene? What do you say, sir?
So thank you for your question, sir. I am honored to get a question from you. One is the location of the aneurysm in the aorta that decides whether the patient needs open surgery, hybrid or endovascular.
How big?
And the cutoff in Western population as well as the international studies is 5 centimeters.
5.5.
But in India, it should be 4 to 4.5 because we are small statured and the index body surface area is lower. So our threshold should be much lower to intervene because not only rupture, the risk of rupture is low. It's about 8 to 12%.
3 to 6%.
Yes, but the risk of dissection is much higher, and that also is catastrophic.
Right. What about the stent graft? What are you using?
It is made of a special alloy called nitinol or nitinol, nickel titanium navy alloy. That's what it stands for. It comes compressed in a delivery device, but when it touches the blood and the warmth of blood, it expands, and the radial force is what keeps it planted in the aorta and excludes the aneurysm from the circulation.
So are there some future directions in the use of stent grafts now?
Stent grafts are very commonly used and they are excellent adjuncts or treatment choices given the right patient and right pathology.
Would you like to have some probably further advance in the stent grafts?
Absolutely. I mean, there is. I'm trained in stent grafts too, so there are a lot of advances coming. Most recently, about 2-3 months ago, I trained in fenestrations of these stent grafts. You don't open the body, but you make holes for the visceral branches.
So I think people have gone for dinner. Let us have question answer for Dr. Batra. So Dr. Kalra, please.
Friends, it was a wonderful talk by Dr. Batra. I wish it was a separate talk because it was vast and we have so many questions. I'll set the ball rolling by asking only small 2 questions. Sir, Crohn's disease and ulcerative colitis, they are very similar but very different. So, smoking and appendectomy, they were both protective in ulcerative colitis and risk for Crohn's. So, are they somehow related also? Because they were having both similar effects.
It's very weak data on both, because how can appendectomy influence the course of a disease? So it doesn't make sense. there was an association, but the data is not very.
So I came across use of heparin orally also for ulcerative colitis. It was a news to me that heparin is available orally. Now that snack technology, which has made peptide pill technology, that has happened. So have you used heparin for ulcerative colitis?
Again, weak data. Even the newer oral anticoagulants, the NOACs, are being used. There are trials that they can be helpful, because one of the postulations is that they are microthrombi which leads to eventually the ulceration that's happening in ulcerative colitis. So if you anticoagulate, then you can cure them, but then again, these are not mainstream recommendations.
So what happens to HIV having comorbidity as ulcerative colitis? Does it help? Does it become more? Because it is all immune related. So how it behaves?
Right. Ideally, it should make that disease go away. So what you are saying is partially true in pregnancy, because pregnancy is also immune suppressed state. So in pregnancy, the incidence, the florid, the manifestations of ulcerative colitis reduce, but that is not true in HIV.
So, Dr. Batra, you said ulcerative colitis can be a pre-malignant condition. So, if you are treating a patient of ulcerative colitis, so how frequently you will follow up for malignancy, like colonoscopy, at what interval you will do?
So after 8 years of disease, every year colonoscopy with multiple biopsies, each taken from every quadrant of the large bowel and 8 biopsies from every quadrant. And including
8 years every year. Every year.
Every.
So, okay. Now, Dr. Tulsi, you can ask questions for Dr.
So, thank you, Dr. Pradhan. Once again, wonderful presentation, Dr. Yogesh.
Thank you, sir.
So, talk us through the serological markers. Inflammatory bowel disease, especially in ulcerative colitis and Crohn's disease, positive PNK and negative ASCA is ulcerative colitis, and negative PNK and a positive ASCA is Crohn's disease. Talk us through the biomarkers, the serum biomarkers regarding these two.
So again, sir, old concept largely has been given up because both markers have not been found to be very valid for the diagnosis of either of the two.
I thought these are recent biomarkers. Anyway, sir, let's proceed further. What about imaging? The CT and MRI angiography has replaced the barium now?
Yes.
Okay, wonderful, sir. And my further questions would be regarding the fecal calprotectin levels, and high CRP and ESR would be, markers of intestinal inflammation. So how often do you use that?
Yeah, we use it.
Especially the fecal calprotectin levels. Wonderful, sir.
Calprotectin can replace frequent CTs or MR. You can follow up the patient with fecal calprotectin rather than advising repeated CTs.
Right, sir. What about, salicylates or methylamine in Crohn's disease? I think probably they have no role today.
No, they don't have any role.
Wonderful, sir. Thank you, sir.
So the newer biomarkers are the ones which predict the diagnosis or the inflammation which is there. So these are fecal biomarkers, they can be serum biomarkers. So these biomarkers are not ANCA and ASCA. These are markers similar to fecal calprotectin.
Thank you, sir.
So, just to be concluding, so Dr. Niranjan's lecture, you rightly said that TAVI should be very carefully selected patients, because unless you said one slide, the removal of that valve becomes very cumbersome. So you have to, in young patients, you have to be very selective. That's so. Just one line on that, then we close.
Absolutely, sir. It's not only low risk, we should also look at the life expectancy of the person. Like if he's a 50, 60-year-old patient and he's quite fit, very active, still doing all kinds of physical activity, and you end up putting a TAVI valve. But the thing is, we do not know how what's the long-term outcome of a TAVI valve. But if he can tolerate an upper hemisternotomy or a mini AVR, surgical AVR, and be able to give a good size valve, then he can have a valve in valve, say 10-15 years down the line, when he's 65-75, and then has another valve in valve because the diameter that is available is much bigger than just putting in native valves.
Thank you for a very educative lecture. Dr. Kalra just can conclude his lecture or is fine.
Wonderful talk, both of them, and many questions we didn't ask because of time. Thank you so much.